Next, we have Dr. Stephen Miller. Dr. Miller grew up in rural Illinois along the Mississippi River. He trained in pediatrics at Duke University Medical Center and later in pediatric sports medicine at Children's Hospital of Akron. He is board certified in both pediatrics and sports medicine. He enjoys helping young athletes manage all types of musculoskeletal injuries. His specific clinical interests include running injuries, pitching injuries, and concussions. Dr. Miller joined Children's Healthcare of Atlanta in the Fayetteville office after practicing pediatric sports medicine in Virginia Beach for over 15 years. When not working, Dr. Miller enjoys fishing, being outdoors, and playing board games with his family. Welcome, Dr. Miller.
Oh, how do I get going? Oh. First, I'd actually like to thank everybody who organized today for just allowing me to be here to speak. I am one of the pediatric primary care sports medicine doctors with Children's Healthcare of Atlanta. I'm going to talk about concussions, managing them in your office. I see a handful of concussions every week, so I've been through this process from beginning to end multiple times. I have nothing to disclose, and when I talk about concussions, I can talk about a lot of different things. Today, I was hoping to keep it to what a concussion is and how you would make a diagnosis, and then spending time on the newer recommendations for concussion management, including how to help students get back into the classroom, as well as how to help athletes and anyone go back to sports or risky activities after a concussion. So a nice concise definition for concussion is a traumatic brain injury that causes temporary impairment of higher brain function without causing visible anatomic damage. And if we break that down, it is a traumatic brain injury. It's typically a direct hit to the head, but it could be an indirect mechanism too, where you get a hit to the body that's sufficient enough to give you a whiplash type injury. Essentially, you need any kind of a trauma that's sufficient enough to shake the brain inside the skull can give you a concussion. And that shaking, that mechanical shaking, causes the brain cells to depolarize, and then that leads to a cascade of metabolic changes that ultimately produce the symptoms. And the symptoms come on pretty quick after the injury. A lot of times you'll have something immediately. It may be very obvious, like loss of consciousness or someone who's just clearly confused and not appropriate. But it could also be pretty subtle. It could just be some lightheadedness, feeling woozy, feeling just not right. And sometimes that can be overlooked or kind of ignored, particularly some of the athletes. But as those metabolic changes kick in over the next minutes to hours, it usually becomes pretty clear something's different with this person because of the injury. So it's traumatic injury, and it affects the higher brain function. So your basic neurologic exam is going to be normal every time. You should have a non-focal neurologic exam for every concussion. The things you're going to see are changes either in cognition, so a concentration memory kind of issues, or central vestibular processing, so feeling like off balance, lightheaded, but there's dozens of possible symptoms they can get. And it's always important to recall that while you can lose consciousness with a concussion, you don't need to lose consciousness in order to have a concussion. And then lastly, there's no visible anatomic damage, at least not that we can see with a CT scan or an MRI. Even your worst concussion, those scans are going to be completely normal. We use those if you're concerned there's a structural brain injury like a brain bleed or a skull fracture. And this one kind of highlights concussion is really more of a brain function injury, not a structure injury. And I always also point out that this is a temporary impairment. So you'll have your injury, you'll have your symptoms shortly afterwards. Typically it's at its worst in those first few days, but then it gradually gets better over time. But that full resolution can still take days or even weeks to get to the end of. So how do we make a diagnosis? And this is the big challenge with concussion, is that there's no single confirmatory test that we can do to say, yes, you have a concussion. What you're experiencing is because of concussion. It's purely a clinical assessment from beginning to end. So to make a diagnosis, you basically need three things. You need to have a trauma sufficient enough to shake a brain, and that needs to be followed by concerning symptoms in a typical time frame. And I look more for brain symptoms because you can get hit on the head, have a headache because your scalp hurts, but you don't necessarily have a brain injury. But if you get hit on the head and they're confused, they're out of it, they're not acting right, that's a brain injury. So trauma followed by brain symptoms, concussion is on your list. Since we don't have a test to confirm that that's what's going on, you're left with excluding the other reasonable options. And early on, that's going to be the structural injuries like a brain bleed. So whatever it takes for you to feel that someone doesn't have a brain bleed, you can say, okay, this is probably a concussion then. But also in your follow-up visits, when they're coming back and they're still having symptoms at a week or 2 weeks, always kind of keep in mind, you don't have a test to confirm this is still concussion. What other things could be causing the symptoms that are persisting? As far as evaluation in the office, the sport concussion group, every 5 or so years, puts out a new set of guidelines with the newest information in it. With this most recent one, they've put out this office assessment tool called the SCOTE 6. They have a child version for 8 to 12 and then an older age version from that age on up. It's really nice. It's free online. You just Google it, it'll come up. It tells you how to do everything in it. It tells you how to interpret things in it. So it's a good thing to have looked at and be aware of. It is designed for managing concussion from days 3 through 30 of the injury. And it's a really thorough assessment. It has all the history that you would need, good ways of monitoring symptoms. It has a very thorough physical exam. It includes some neurocognitive testing that you can do, an easy one in the office you can do. And then it has validated screening tools for the different ages for sleep and different mood disorders. And I find that one helpful, particularly people having kind of persistent symptoms. And then at the very end, it has little reminders on what the current guidelines are, the current recommendations for returning to school and returning to sports are. So I like it because it is thorough, but because it's thorough, it's also a little bit overwhelming. I look at this as this is the toolbox with all the tools in it that I can use to assess concussion, but I'm not going to use every tool at every visit for every person, so I can kind of pick and choose. I have the things I use regularly, and then a few things in the toolbox I might pull out on occasion. So what are at least the basics you should be able to do in the office? Well, first, you want to make certain you have the right diagnosis when they come in. So you want to review what the injury was, and then you want to assess what those brain symptoms were afterwards. And I not only ask the patient how they felt or what they were experiencing, but I try to get what other people could observe in them, because I think is a little bit stronger too. If someone says, oh, he was just clearly not right, that means a lot to me as opposed to maybe a little bit lightheaded or a little bit of a headache. The SCOTE does a good job of covering like a pertinent past history. So it's a nice form that parents can fill out. It makes certain you kind of looked at past head injuries and various different comorbidities that may make assessing recovery more challenging. And then what it really is good at is it has a nice way of assessing symptoms. So when you see them for the first time, and when you see them in follow-up, you should always be seeing what their symptoms are like at that time. And it has in it a symptom scale with graded severity of each symptom, and it's meant to be filled out by the patient. So the child version is actually worded appropriately for younger kids, and then you also have a caregiver fill it out. So you also get to see what the parent is seeing in the child, and sometimes that can kind of open your eyes a little bit as to what's going on. But I also like it because you can take those weighted scores and you can add them up, and it gives you a total symptom burden or total symptom severity, and you can track that from visit to visit. And with concussion, that number should be improving as they improve, so it should be going down. I also personally like to use that symptom scale. There's about 24 symptoms on that symptom scale, and I divide them up into different groups or domains. And it's just a way for me to also look at that before I even go in to see the patient to say, oh, there's a lot of headache going on here, or there's a lot of cognitive things going on here, or maybe sleep is really a big problem for them. So I can kind of see where their problem areas are. And I also like to point out at this one, these are a lot of those symptoms on that symptom scale, and there's no symptom there that is specific to concussion. Many other things could be causing all of these symptoms. which again makes managing concussion a little bit more challenging. One of my hints, though, is that symptoms from the concussion, symptoms caused by the concussion injury, often get worse whenever someone is doing more cognitive exertion or more physical exertion. So that's a good follow-up question when someone's having headaches or other symptoms, like what makes it get worse? And are you finding oh yeah, when I really have to use my brain or I really get my heart rate up, that's when things get worse. That's a little bit of a clue. As far as exam, again, you need to do enough of a neurologic exam that you're comfortable they don't have a brain bleed. And whatever that is for you, that's adequate, I think, for the neuro exam. For me, it's typically looking for if there's anything focal on it. But I also encourage you to be looking at their neck, because if they've had a trauma sufficient to shake their brain, they usually have had a trauma sufficient enough to get a neck strain. And neck strains will tighten, and they can generate headaches, and they can generate their own symptoms, and you want to address those too, particularly those early on ones. So at the very least, have them show you a full range of motion. Feel along the muscles on their neck. If they're sore, they're tight, give them some guidance on things to do. It's easy stuff up front, some basic stretches, some massage, sometimes even Tylenol Motrin help a lot at that early stages. And if it's something that just seems like it's lingering and they still clearly have problems, physical therapy could be appropriate. Now, the SCOT has a lot of what I call bonus exams. And they do a good job. If you read through it, a good job of describing them and what you're trying to accomplish. There are a few of these I do regularly, but I definitely don't do all of these at every visit. So I'd encourage you just to look at if you find something in there that you think would be helpful for you to use. It's just another tool in the toolbox. As far as managing concussion, this is probably the most important slide. Concussion management can really be boiled down to just a couple of rules. The first rule is no risky activities. Our first goal is don't let them get another brain injury. So I tell them, I sit down and talk to the patients, I talk to the family. You should do absolutely no activity where there's a chance you could get hit in the head, knocked to the ground, or get another whiplash injury until I say it's okay. So that's rule number one, no risky activities. That's what a risky activity is. Rule number two is if it's not a risky activity, we should be encouraging them to do that, but at a tolerable level. And that's following what we call the Goldilocks principle. You're looking for that just right level of engagement that doesn't make them feel terrible. And that goes against a lot of what, even in the last few years, have been recommendations for 10 or 15 years. Things like cocoon therapy, where people isolate in a dark room with limited stimulation, sometimes for days, avoiding any unnecessary cognitive exertion, including no school, sometimes for days or even weeks, and then avoiding any unnecessary physical exertion or exercise until essentially you're almost back to normal. And these have changed in the most recent guidelines because over the past 5 years or so, there have been a lot of studies that have clarified this and made it a little easier to say, this is what we should be doing. And these are kind of some of those studies. So first, what's with the cognitive rest? And this study here is actually one of the older ones, has been around, a randomized controlled trial, relatively young patients. Everybody was enrolled in the study within 24 hours of their injury. So they caught them early and said, this is the intervention we want to do. And when they designed this study, they were looking to see, hey, if rest is good, more rest is better. So the intervention group was said, 5 days at home, you're doing nothing. And the other group, what they termed usual care, allowed 2 days, 1 to 2 days at home, and then start going back to activities, or at least go back to school as tolerated. But what they found was that there was really no difference in the recovery pattern between the two groups. There was no difference when they did neurocognitive testing between the two groups. And then when they looked at the group that stayed home longer, they actually reported more symptoms and more intense symptoms over that time. So what we take away from this study is that a long school absence does not help kids get better from concussion faster. And that longer absence may actually make them feel worse. So the newer recommendations are stay away from a prolonged absence, still consider a couple of days, maybe up to 3 days at home, but don't do cocoon therapy. Allow them just everyday activities at home. And then after that, we try to do everything that we can to give them a structured way of trying to get back to school, and that needs to be individualized to what kind of symptoms they're having, how intense their symptoms are. And I'm going to talk more about this in a few minutes. What about use of screens? That's been a big one where we've really tried to avoid screens for as long as people are symptomatic. This was just a couple years ago. Slightly older, but still average age 17. Again, everybody enrolled within 24 hours of a concussion. One group is told to use absolutely no screens, no TVs, no phones, no computers, and the other group allowed to use as much as they wanted. And you can see even in the abstain group, they still had almost 45 minutes a day on average, which isn't a lot, but still some. And they found in this case that people who abstained from the screens actually did recover faster. And so what I at least take away from this one is that, yes, if you see someone early, being strict about screens early on may be beneficial to the recovery. I also point out that it's strictly reduced screen time. It's not 100% reduced screen time. So a little bit of checking on using screen is okay. And the newer recommendations kind of reflect that. So if you see them early, you can go ahead and recommend avoiding screens as much as possible in those first 3 days. But the newer recommendations also concede that there's no evidence that being really strict about screen reduction after the 3 days improves their recovery. So at this point, the recommendations are to allow them to use screens, but again, you got to find that tolerable level. And I still talk to families and say, okay, as we're starting to use screens again, let's at least try to prioritize academic screens over like recreational and social screens. So for me, once they can start showing that they're performing in school, they're using screens to do schoolwork adequately, like as far as I'm concerned, they can do as much recreational screen time as they want, or as their parents would allow at that point. And then what about physical activity? And this is an area that probably has some of the more study than others. And a lot of it comes from Dr. Leedy, who's out of Buffalo. And he's done a lot with exercise in prolonged recovery from concussion. And then this was his first study where he looked at exercise immediately after a concussion. And so it was an RCT that he did at his practice with teenage concussion patients diagnosed within 10 days. And his test, he's developed a treadmill test where the injured person walks on a treadmill. They monitor the heart rate continuously. The incline gets more every minute, and so it gets harder to do. And the goal is to find what's that heart rate that they have that really makes their symptoms get bad. And he calls that their symptomatic heart rate. And then what he would do is say, okay, now your prescription is to exercise at 80% that level. So you're never going to quite get to that intensity that causes worse symptoms. So that's different for every person he sees. And so he used this kind of protocol. So one group was given aerobic exercise, 20 minutes at that target heart rate, compared to another group that was given 20 minutes of stretches designed so that the heart rate should never go up. Everything else in the management between the two was the same. And what he found was that there was no difference in the symptoms reported. So even the people exercising right away were not reporting more symptoms, and that the people who exercised got better significantly faster. In his first study, there were fewer people in the prolonged group. A prolonged recovery is anything more than 30 days. It wasn't statistically significant, but was a difference. He then expanded that study, added in a few more pediatric concussion centers, same protocol, same interventions. And what he found was the same thing again. The exercise group recovered significantly faster. There were fewer people in the prolonged recovery group. And in fact, if you were in the exercise group, your chance of having a prolonged recovery was cut in half. So what do we take away from this? That exercise, at least done at a tolerable level right after a concussion, is safe. And that it actually seems to be one of the things they can do to improve their chances of recovering faster. And so the newest recommendations are going to be to actually encourage some exercise as early as 2 days after a concussion. But again, you're looking for something that's tolerable with a goal of 20 minutes. And again, we want it in a safe environment. But this does not include higher intensity. So this isn't like your all-out high-intensity weight training kind of activities. So how do I put like all these new studies and recommendations together? I follow my 2 rules. I'm always going to follow rule number 1, absolutely no risky activities from the day of your concussion to the day I clear you. And then if you see them early, you can recommend a couple days home a couple days home from school. Easy everyday activities, essentially avoiding anything that aggravates their symptoms too much. Try to minimize screens in those first 3 days. And I've added in here prioritizing nighttime sleep, and this is probably even beyond the 3-day mark is beneficial. It's not in the most recent guidelines, but in the past 2 years, there have been a few studies that are hinting that not only is sleep important for recovery, but having a consistent nighttime sleep is probably more important than getting a lot of sleep throughout the daytime. So I will let my patients, particularly early on, if they need a nap in the middle of the day, that's fine with me, but I don't ever want the naps to start making getting to sleep or staying asleep more difficult. So if that happens, I have them limit no more than 30 minutes. So after those 3 days, then it becomes rule number 2. Anything that's not risky, we're going to try to normalize. So we're going to try to get them back into school. They're going to need some accommodations. They can start using screens at a reasonable level, and we should be recommending some exercise. But all of these recommendations are going to be individualized to the person and the types of symptoms they're having and how bad those symptoms are. So to talk specifically about some of those newer changes, so the return to activity or return to exercise after concussion, I kind of think of this as exercise as medicine. This is something they can do to make their recovery faster. Because we know that it is safe and can be done as early as 2 days after the concussion, even if they're still having symptoms. But we're still following rule number 1. This is not sports. This is not doing anything risky. It's not licensed to do more. And again, the goal is 20 minutes every day, finding a tolerable intensity. If you read the guidelines, they'll say things like, well, yeah, your symptoms can get worse when you exercise. We know that. But that aggravation should be mild and brief, are the words they use. And they try to put a little bit of a description on that. So I don't get into this as much with my patients, but I say, a little bit of symptom aggravation is okay. I don't want you to be miserable. So if you have done a workout and then you're like wiped out for 3 hours afterwards, you pushed too hard, you found your limit, you went past it, next time go a little less. But if you want the exact definition they use, this is it. And then they're going to improve. And the concussion protocol that Leedy uses actually gets harder as they can tolerate more. He keeps finding their new target, their new symptomatic heart rate, and ups their exercise appropriately. So as they're feeling better, it's okay to give them a little bit more intense exercise. I usually just start with walking. I say your first goal is walking 4, and I try to get to 20 minutes. If someone's horribly symptomatic, I'll even say, okay, just 10 minutes outside on a treadmill with a family member, with a dog. Just try to do something. Once we get them 20 minutes more regularly, some of the athletes want to do more. Some of the people who go to the gym regularly want to do more. I'll let them start to jog. When the athletes are also feeling better, it's okay to let them start to do some individual sport-specific activities. But they're still not doing anything with the team yet. If they're still having symptoms, they're not doing anything with other players. So a basketball player can dribble a ball and shoot it, but they're not going to play basketball or run drills with the team. Soccer player can kick and shoot, but no drills with the team, no games, while they're still symptomatic. And again, in this recovery, exercise as medicine, it's relatively low intensity. It's not going to be super hard sprints, wind sprints, heavy weight training. And then again, I like to point out, this is not the same thing as the return to play progression. This is exercise when they're still having symptoms. Return to play is the test that proves everything's better, and that's at the end. As far as the return to school process, I encourage you, and I always do, every visit I see them and follow up, I give them a new note to take back to school. So the school knows where they're at, because things should be getting easier as they move along. And I think of the return to school process first of just attendance. We know we don't want to have a long absence from school, a couple of days. Majority of of kids are going to be able to tolerate full days after that 1 to 3 days. Some will just need a few accommodations, but some of them are going to need a lot. So you just try to write out as much as you can to try to make that transition tolerable for them. You will get some, though, a few who just can't do a full day, and those are the ones I'll do a partial day. My way of doing it is I just ask for half days, and I say try to get as many core classes in that half day as possible. I leave it kind of open so the family and the school can work out what works best for both of them. My other opinion is if they can't fully attend school for full days, they probably shouldn't be doing tests or turning in assignments. My focus then is for them to focus on being present in the classroom, being used to being around everybody, being used to getting up and changing rooms before they're fully participating or being asked to perform in the classroom. And anytime I give somebody a partial day attendance, it always comes with a deadline. And I based on what I think they'll be able to do, 2 to 5 days, and I say, okay, they go to full days at this day. And then I follow them every week. My goal is I don't usually go any further than that until I know they're attending school and doing a better job of participating. Because then once they're doing that, really the next thing is when can they do risky activities once they're kind of back on their routine. So one is attendance when it comes to writing that school note, what can they attend? And then the second part then is participation. So again, this is all individualized to the person in front of you. I use this a lot because I think it gives a lot of flexibility. Sometimes it's just a matter of getting the student to use what I'm giving them. But I say, please let them take a rest break at their desk with their head down at any point they need to. So they can use it when they need to for as long as they need to. And the whole idea there is they can take that break when they feel things getting worse, potentially starting to build up, and you can kind of close your eyes, take a few deep breaths, kind of zone out, relax a little bit, try to not let the symptoms get so bad that they kind of get overwhelming. But of course, if they can't control their symptoms adequately at their desk, then I allow them to go to a quiet place, usually like a nurse's office. And again, I put a time limit on it, 30 minutes, and then I anticipate they're going to try to go back to class. Also writing things like, particularly early on, like giving them all the time they need to finish a test, potentially giving them a delayed deadline or postponing tests or even bigger assignments if needed. I still encourage the students to try to do something, to not just let everything build up, because then you have an overwhelming amount of work to catch up on. But let them go at their own pace, which may mean they need to delay some deadlines. Screens are allowed, as we said, but almost everyone will need this one, at least letting the school know, hey, they can do things like dim their screens. They're going to probably need to take lots of breaks because they're going to go at their own pace. With that comes delayed deadlines. And it's always nice if there's something that's done on the computer that could be printed onto paper and completed. That makes things easier for a lot of people too. And then just kind of symptom-based accommodation. So a lot of light sensitivity, let them wear a hat or sunglasses. If there's noise sensitivity, cafeteria can be a rough place. I usually let them have lunch in a quiet place. And since I don't want anybody to have lunch alone, I ask if they can have 1 or 2 friends. And I usually put in if needed. Some kids will use this. Some kids would rather just be with everyone. And then thinking about some of the noisier classes, either avoiding them or trying something like earplugs or noise canceling headphones to make those more tolerable. I don't know that many of the kids do notes anymore, but if they can get photocopied notes so they don't have to kind of keep up early on. And then not uncommonly, you'll find someone who's really struggling with a particular class, and it's usually a class that they weren't very strong in to start with, but they have a hard time catching up on it. And just informing the school, hey, they need some extra assistance, some extra tutoring, or just some extra instruction from the teacher. And then on every school note, don't forget to include an activity portion to it. So the school knows where they're at, that they're on rule number 1. No risky activities until you've written a different note. I also feel pretty comfortable, particularly with my high school athletes, particularly if they have like a weight training class as opposed to just a Gen PE class, also writing on there, hey, light exercise has been shown to improve recovery. Please allow them to walk or jog at a comfortable pace for 20 minutes every class, but no high intensity, no weight training yet. When you are trying to individualize these things to the patient in front of you, a couple of hints that are good to know about concussion. One, yes, if they push themselves too hard, they're going to feel worse, but that should be temporary. Okay. If they push, you found your limit. Next time you just go a little less intense, but it's not causing any further damage. And the natural history of a concussion is one of steady improvement over time. So yes, someone pushes too hard, they can have a bad day, but it's unusual for a concussion to cause someone to significantly go backwards down the road. So if you have someone who's really regressed for a significant period of time, that's unusual. Again, think about all those other things that could be generating those symptoms and make certain you address and manage those things. And then that brings me to the return to sports, which is really the return to risky activities, which is really asking the question, when is it okay to break rule number one? And we need this goes back to the same thing. We don't have a test to tell us they're all better now, so they're ready to go back. So it's a clinical assessment, and we're looking for them to be back to their normal selves. I say no symptoms, but it should really be their normal selves, because an ADH person can say they have some concentration issues, that sort of thing. You want to get them back to their baseline selves at rest, using their brain to maximal potential. So at the very least, they should be full days at school with normal participation, with no symptoms. And then lastly is that they can work out to high intensity and have no symptoms come back. And that's that return to play progression. And I tell families, this is the final test. Okay. This is what we're looking to pass next. And if you haven't seen the return to play progression, they're available online. There's one in the SCOTE that's generic. You can give to any athlete or any person. Children's has some sport-specific ones that you can find online and print out. So football, cheerleading, soccer, lacrosse, gymnastics, cheerleading. We have all of those. And essentially, it is a series of stages. Each stage has a workout. Every next workout is harder than the one before it, until ultimately you get to the end and they're playing sports again. And the goal here is, again, proving that their concussion is better. So they need to move through all of these stages and have no symptoms. No symptoms while they're doing the workout, no symptoms at school, no symptoms at home. And they can only do one stage per day. So this is going to take a couple of days to complete. And that's giving us like 4, 5, 6 days to prove that they're still back to normal. Now, you can always add more to that. So if you had a special case where someone maybe has had a couple concussions already, or had a concussion just a couple months ago, and you want to be extra certain they're better, you say, okay, there's 2 days at each stage as we go through. What happens if they have symptoms during this time? We have them rest until they're feeling back to their normal selves. We drop back a stage and we let them try to keep progressing. If they have to do that more than once or twice, it's definitely worth kind of reevaluating them. And then in general, everybody should have a full team practice, at least one full team practice before they're back out competing in a game. And if you have a high school student who has access to an athletic trainer at the school, this is what they do. Like, it's a phenomenal resource to have. You can just write, they're ready to do the return to play progression under the school trainer's guidance, and they will walk them through that six or seven stage process. And if they have trouble, they'll send them back to you. And again, this is the final test. If they've made it through all of this, good at home, good at school, no symptoms over the several days of this return to play progression, they've passed the final test. And concussions are like bruises in that some bruises are worse than others, some bruises will last longer than others, but when it's gone, it's not going to come back next week or next year. And the same is true here. If they've proven that this is better, they're not going to have problems from this concussion next week or next year. They can always get a new one, but this one's done. And I review that with families too. And then I just like to end with, these are some places you can get more information. Children's has good handouts for parents and patients. There's a more in-depth return to classroom guidelines. We had copies out at our table, the guidelines for return to sports, and then CDC Heads Up always has up-to-date information. And if you weren't aware, Children's also has a concussion nurse. That's what she does 5 days a week. You can call Children's, ask for the concussion nurse. She can give you advice in the office. She also calls families and checks in on them, sees how they're doing, offers them advice, helps them get plugged in with appropriate providers from there too. Okay. And that's what I wanted to cover today, but I'm open to questions on any part with concussions. Any questions with concussions? Problems you've had?
About reading, like books. So that is not that book books. I mean, instead of their new screen time, read too much or.
So, and it's all Goldilocks. It's like what's tolerable. I find that screens are more challenging with time. So reading from a page is typically easier than reading from a screen to start. And you just find that tolerable level. And in that first 3-day part, like I don't mind them reading from a book, but I'd probably stay off of the screens. And you know, people ask about, you know, like I'll let them play games, you know, with family, and it's okay to be out of the house. It's okay to do a little bit of stuff. I just encourage like just normal stuff. The other thing I do too is I try to, even if they're not going to school, like try to get up at a decent time, and to try to go to bed at a decent time. And people who go into winter break, people who go into spring break before that, just trying to keep them on that over that time too.
Is there any special diet that you recommend for them?
The biggest thing I recommend is like not skipping meals, because your brain runs on carbohydrates. And so if you're not eating regular meals, you're going to have those low blood sugar times, and that's going to make you feel worse on top of the concussion. I don't know that there's evidence to say that that makes it worse, but it's going to make you feel worse. So just making certain they stay on, don't skip meals is my big thing. And sometimes you'll see too, like you'll talk about the headaches with them. And if you ask them a little bit, like, when is it bad? Like, it's like, oh, it's the end of the school day. Double check that they're eating lunch, or maybe they need to bring something as a snack right before the end of the school day too.
I get to see them when like we get to the ER, and then they come and like, oh, I'm ready to go back to the base. So if they're reporting to me that, oh, I'm fine, I'm back to the beach, sometimes it's because they want to go back to play. But if my exam is okay, do I have to go through the steps of the return to play?
Yeah, so if someone, I think of concussion as like there's a switch that's gone off. If they've shaken their brain enough to get those symptoms, then they have an injury, and they have an injury that's going to take some time to improve. So even if they feel better fast, we need to go through all the steps of proving that they're fully recovered and not 80-90% better. So I still, yes.
So usually then I'm like, because the ER will probably tell them, "Sis, don't wait for 2 weeks." So they're coming to me after that.
After that, so yeah, so that's the issue then. So, what I always like to do when I have that situation, you're saying somebody 2 weeks out, who clearly had something that happened early on. I usually like to know how long have they felt as good as they feel right now. And if they're telling me just a day or two, then I'm like, yeah, you need to do the whole thing. If they're telling me it's been 10 of the 14 days, I've been completely normal, and the parents say they're completely normal, it is nice. Some of those SCOT exams are look for some of those kind of subtle things they may not be able to hide as well. So that might be all. If I still have some questions on that, you might go a little slower with them if you do some of those bonus exams. But at the very least, I want to know that and then my next question is what have you been doing activity wise? And if they tell me I've just been sitting around doing nothing, like you've got to show you can do all of these things. If they tell me, I've been running a mile, most days, I don't get headaches, I don't get lightheaded, I don't feel unusually tired afterwards, I feel normal through all that. I've been weight training, that's one of the higher intensity things there. And I'll say, well, we might do a modified thing. If they have a trainer, I'll say, run them through like some of the non-contact drills and some really intense agility stuff to make certain that they're good, and then a full practice and then a full game. So I might modify it a little bit, but they still have to prove to me that they can do high intensity They can do full days at school, use their brain and have no symptoms, and then high intensity exercise with no symptoms before I'd clear them to be in a game. So nobody's coming, there's almost nobody who comes into me on day one and gets to play football that night. They're going to have a few days. Yeah, and on my first visits, I often say that too. This is what it takes to get cleared. So on the day they come to tell me that they're 100%, I'm not clearing them to play that afternoon, but they're going to start that few day progression that will get them back to playing. So they kind of know that expectation.
Is it normal that after a concussion, the student will have like a blur vision?
Yes, I didn't. So I only covered the bigger updates, but yes, that's part of that central vestibular stuff. And on the bonus exams, the first 3, 4 of those are all about like vision coordination. But what you tend to get is it tends to have more of like a vestibular trigger. So it's either they're moving and that things just go blurry temporary, or they're trying to focus the words on the page and they either go in and out of focus, or they keep skipping lines. The words jumble a little bit. And for that, I'll say, go back to first grade and get a little bookmark and use for following your line, and just stay within what's tolerable. And it tends to improve, like everything else with concussion, tends to improve with time. If you have somebody who's having vestibular or vision symptoms like that are 10 days out. So they're saying, I get lightheaded if I move quick or I stand up really fast, and it's like a real consistent issue for them, or you're finding some issues still on those bonus tests, then that's the new guidelines say that's the time to consider going to a vestibular therapist. So a lot of physical therapists have somebody in their office who does vestibular therapy, and that's been shown to help it at that point. I don't usually do it any earlier than that.
So for how long do you think that blur vision sign and symptom will last?
So everybody's different. It's going to last as long as it's going to last. It's like, how long is my cold going to last? But I typically within a week or 2 weeks, most people are not having big trouble with that. So if you're getting out 10 days, 14 days, and someone's definitely, if they're having problems getting function done because of that blurriness, the rehab should help. And it's intermittent. It's not like it's blurry all the time. I can't see anything. It's like I try to focus and it goes in and out. Mm-hmm. And that's a not uncommon one. If you don't ask about it, sometimes you don't get it. You don't hear about it. Okay. All right. Well, thank you.